Now, in radionuclide imaging, what is done is a radioactive isotope is taken or a material is taken and this material is tagged with a radioactive isotope and that is given either orally or IV route. And this isotope or the material that is tagged with this isotope, when it enters into the body, the organ of the interest or the pathology of the interest selectively and actively takes up this isotope or the material tagged with isotope, and that material, that isotope starts decaying in the body and that emits certain radiations. And these radiations are taken up either by gamma camera or a PET camera, right? So radioactive isotope is taken, or there are certain materials which are actually taken by the body, but they cannot emit those radiations. That is why a material is taken, and this material is stacked with radioactive isotope. For example, if iodine 123 is taken, this iodine 123 is in itself is a radioactive isotope, and it can be taken up by the thyroid tissues. But if you take something like MIBG, that is not radioactive in itself, so that is tagged with the technetium-99M, so that it becomes a material tagged with the radioactive isotope. Now, this is given either via oral route or via the IV route, and this will be taken up by body tissues, which is an organ of interest. And once it is taken up, this radioactive isotope decays. As it decays, this emits radiation, and this emitted radiation is picked up either by a gamma camera or by a PET camera, and then that will produce either a 2D image or a 3D image. Right? So this is a functional investigation. This is also called as scintigraphy. This finds application in thyroid disorders, parathyroid, adrenal, and renal, and most of the metastatic diseases. But most commonly, it is used in a thyroid disease. So the isotopes that can be used in a thyroid disorders can be iodine 123, iodine 131, or technetium pertechnetate. 99M technetium pertechnetate can be used. Now, this iodine 123 has a half-life of about 13.2 hours. Iodine 131 has a half-life of about 8 days, and technetium 99 pertechnetate has a half-life of about 6 hours. This emits gamma radiation. 131 emits beta particles plus gamma radiation, and technetium emits gamma radiation. Now, the gamma radiation emitted by the iodine 131 is of high energy, and a high energy radiation is not well suited for a imaging. Along with that, this iodine 131 has emission of beta particles. Beta particles destroy thyroid tissue. And because it destroys thyroid tissue, it is used for therapeutic purposes. The main use of iodine 131 is for therapeutic purposes because it has longer half-life of about 8 days, and it also emits beta particles in addition to gamma radiation, so that it destroys the thyroid tissue, and that is why it is used for therapeutic purposes, which is called as radioiodine therapy. Now, the gamma radiation emitted by the technetium 99M is of low energy, which is very well suited for imaging purposes, and also it has got low radiation absorption dose. So that is why it makes up for excellent diagnostic purposes. It has got a short half-life. It emits only gamma radiation, and that gamma radiation is also low energy, and it has got low radiation absorption dose. So that is why it is called as. It is excellent for diagnostic purposes. Iodine 123 is a half-life of 13.2 hours. It also emits gamma radiation, and it is also used for diagnostic purposes. So when iodine 123 or iodine 131, this is usually given by the oral route. When it is given, it is taken up. So this is, it eventually enters into the blood. So in the blood, the iodine particles are moving around, the thyroid gland selectively takes up this iodine. Right? And this entry of iodine into the thyroid cells is via the sodium iodide symporter. Along with the sodium, iodine enters into the thyroid cells. And once it enters the thyroid cells, these thyroid cells incorporate this into the hormone synthesis. So, along with the normal iodine that is present in the dietary form, this radioactive iodine, which is given in oral form, this is also incorporated into the hormone synthesis. And then it starts decaying. When it starts decaying, it emits radiation, and that radiation is captured to produce the image. Now, when you take 99M technetium, this technetium is a iodomimetic compound. It mimics iodine. So, because it is a iodomimetic compound, it is also taken up by the thyroid tissues through the sodium iodide symporter. And once it gets inside, it is not incorporated into the hormone synthesis. So that's the only difference. Iodine gets incorporated into hormone synthesis. Technetium 99 does not get incorporated into the hormone synthesis. It stays in the thyroid cell, starts decaying, and by emitting the gamma radiations, which is captured to produce an image. Now, what are the applications of this? As I told you, it is both for diagnostic purposes and for therapeutic purposes. So, for a diagnostic purpose, it is basically a functional scan. If lots and lots of activities going on, it will take lots and lots of iodine and it produces a enhanced uptake on the image. So, for example, if it is an autoimmune thyroid disease like a Graves disease, now the entire gland will have diffuse uptake. So, there is diffuse increased uptake in the entire gland if it is a Graves disease. But if it is thyroiditis, then there is a diffusely reduced uptake. So diffuse reduced uptake will be there if it is thyroiditis. And third, if entire thyroid gland is normal, but there is one autonomous nodule which is hyperfunctioning, then that will produce a enhanced uptake that is called as a hot nodule. So hot nodule is one where the uptake is much higher compared to the rest of the gland. So this is a hot nodule, which is a autonomous functioning nodule. Or if it is a multinodular goiter, there are multiple nodules. Each one of them has a different rate of uptake, right? So it helps us. Some of them take a lot of uptake, some of them a little uptake, some of them do not uptake at all. So in case of a multinodular goiter, it helps us to classify as the nodules into hot, warm, and cold nodules. The hot nodules are least likely to be malignant, while a cold nodule is more likely to be malignant. So that is why it helps us to take the FNACs also when multiple nodules are there. We preferentially take FNAC from a cold nodule. Also, if there is an ectopic thyroid tissue that can be found out, it can also be used for a diagnosis of a retrosternal goiter. And after thyroidectomy is done, if you want to see if there is any remnant disease, so post thyroidectomy scans for a malignant disease. Also for recurrence of the disease, lymphatic metastasis, or for distant metastasis. So wherever there is a thyroid tissue, we want to categorize whether this is hyperfunctioning or hypofunctioning. This can be used. So these are all the diagnostic applications. But as I told you, iodine 131 also releases beta particles which destroy the thyroid tissue. It also has therapeutic applications. Now, these therapeutic applications, again, in case of a Graves' disease, you can give a radioiodine ablation therapy, or it can be used in case of a toxic multinodular goiter, or there is a autonomous functioning nodule to ablate that. This can be used. It can also be used for recurrence or residual well differentiated thyroid carcinoma. So either it is a papillary thyroid carcinoma or follicular thyroid carcinoma. So if after surgery, if the residual or remnant is used and there is an indication for therapeutic ablation, so this can be used, but it cannot be used for a anaplastic carcinoma or medullary carcinoma of the thyroid. So for it to get ablated, it needs to have a uptake of the iodine. So these tumors, because they are not anaplastic tumor is not at all well differentiated, so it does not behave like a thyroid tissue. That is why it will not uptake a radioactive iodine, and that is why it is not useful in such cases. Therapeutic application of radioiodine is again a entirely different topic. This is the class about radionuclide imaging. So we'll have a separate class for these therapeutic applications of iodine. Now we'll see what happens in a parathyroid. So if I want to summarize, in case of a thyroid, you can use either iodine 123, iodine 131, or technetium 99 for technique. Now, this emits gamma radiation, this emits gamma plus beta radiation, and this emits gamma radiation. This is excellent for diagnostic purposes. This is also used for diagnostic purposes, and 131 is used for mainly therapeutic purposes. This is given via oral route, and this is given via oral route. Technetium 99M is given via IV route. Now, along with this, you can also use technetium MIBG, sorry, MIBI, technetium MIB. You can also use 18-FTG PET for distant metastasis. So even these can be used for thyroid diseases. So these are all the radionuclide options available for a thyroid disorder. When it comes to parathyroid, so initially they did not have a radioactive iodine which would be taken up only selectively by the parathyroid. So what they did is they took a tracer A and tracer B. They took two tracers. So the first tracer would be taken up by both thyroid and parathyroid, and the second tracer would be taken up only by the thyroid. Now they got the images and digitally they subtracted these images. So this produced an image A, this produced an image B. So they subtracted image B from image A digitally, and so that they got a imaging of the parathyroid. So they used two tracers and they got the image and then they subtracted. That is why it is called as dual double tracer subtraction parathyroid scintigraphy. So these kinds are called as parathyroid scintigraphy because two tracers are used and one image is digital subtracted from the other. It is called double tracer subtraction parathyroid scintigraphy. But this is absolute now. What we use now is a dual phase parathyroid scintigraphy, which is nothing but a system EB scan. Now here 99M technetium EB is given. Now this is taken up both by thyroid plus parathyroid. But from the thyroid, it leaves thyroid earlier. So there is earlier washout, but it remains for longer in parathyroid. So when you give it, it is taken up both by thyroid and parathyroid, but in thyroid, it washes away earlier. It remains for longer in parathyroid. So if you can sequence your imaging in two phases, then you will get a scan of a parathyroid in the second phase. So that is why it is called as dual phase parathyroid scintigraphy or a system EB scan. So here the IV injection of technetium 99M is given, and then neck and CT image, chest images are taken. This is taken first at 15 minutes and then it is taken at 2 hours. So initially it will be taken up only by both by thyroid and parathyroid, and by the end of 2 hours it will be present only in the parathyroid. So thyroid gives an image of early uptake plus early washout, and parathyroid gives an image of early uptake plus persistent presence. Right? So this is called as dual phase parathyroid scintigraphy or a SESTOME scan. Now, if you add SPECT CT along with that, plus SESTOME scan, this is a best investigation option for parathyroid diseases. Adding SPECT CT to this will increase the sensitivity and it will increase the specificity also. So the best investigation for a parathyroid disease would be a SESTOME scan with a SPECT CT. Now, what are the uses of this? So first is it will help us to look for parathyroid hyperplasia or a parathyroid adenoma. Also for a parathyroid carcinoma, although it cannot differentiate between adenoma and carcinoma, it helps us to tell about lymphatic mets, also about distant mets and recurrence of the disease. Also, if there is any ectopic parathyroid. So this is all about radionuclide imaging in parathyroid. It can also be used for adrenal. So as you know, adrenal has both the cortical tumors and it has medullary tumors. For cortical tumors, a cholesterol analog is used. And this cholesterol analog is either in the form of NP59 or sintadrine. So this is a cholesterol analog, which is a steroid precursor, and that is taken up by the cells of the adrenal cortex. For medullary, the options that we have is a octreoscan, where DTPA is used. For a case of pheochromocytoma, or for a case of paraganglioma and the neuroendocrine tumors. So it can be used for both cortical and medullary tumors. So in case of cortical tumors, it can be either used for a glucocorticoid excess or it can be used for mineralocorticoid excess or tumors that secrete the mineralocorticoid and also for the evaluation of adrenal incidentaloma. Now, if there's a Cushing syndrome where there's a glucocorticoid excess, this can be ACTH dependent or ACTH independent. So if it is ACTH dependent tumor, now there is secretion of lots and lots of ACTH, which will act on both the adrenals, the right and left adrenals, both the adrenals, it will act on that, and both the adrenals will start secreting more and more hormones. So that is why there is a bilateral symmetrical uptake. Right? So there is bilateral symmetrical uptake if it is a ACTH dependent tumor. But if it is a ACTH independent tumor, in such tumors, there is a on the adrenaline, there is a hyperfunctioning adenoma only that is enhanced. So there is a unilateral enhancement is seen if it is a ACTH independent tumor. If it is ACTH dependent tumor, bilateral symmetrical uptake will be seen. So in case of adrenal medullary tumors, the MIBG can be used or octreoscan can be used. This octreoscan is for neuroendocrine tumors, for paragangliomas, Now, MIBG scan is for pheochromocytoma. So this is about uses of radionuclide scanning or reduce. Then in case of kidneys, in kidneys, this radionuclide scan can be used to assess the function of the kidneys, and they can also be used to assess the structure of kidneys. So it is called as functional imaging and a morphological imaging. To assess the structure of a kidney, you can use a technetium 99 labeled glucoheptonate or technetium 99 labeled DMSA. So DMSA is for structure. Now, after 6 hours of injection, only 6% of glucoheptonate is remaining in the cortex of the kidney. But after 6 hours of administration, DMSA will remain up to 34%. Up to 34% of the DMSA is retained in the kidneys. So this becomes a tracer of choice for structural abnormalities of kidney. So to assess the morphology, the tracer of choice would be technetium 99 labeled DMSA. Now, when it comes to function, there are three isotopes that are used. One is a iodine labeled hipuran, or it can be technetium labeled DTPA and technetium labeled MAG3. Now, iodine labeled hipuran is used to assess renal plasma flow. Technetium DTPA is only filtered by kidneys, and this is neither reabsorbed nor it is secreted by the tubules. So it is only filtered by the glomerulus. So this is used to assess the glomerular filtration rate. Right? Iodine hipuran is for renal plasma flow, and DTPA is for glomerular filtration rate. And MAC3 is the tracer of choice for functional abnormalities. So when you give a IV radioisotope, now it first in the first minute it will go into the vessels of kidney, and in the second and third minute it goes into the renal parenchyma, and by third to fifth minute it will remain in the pelvic ileal system, and after 10 to 15 minutes the amount in the kidney reduces and it remains in the bladder. So when you take the scan, this phase is called as vascular phase, first minute, and second to third minute is a parenchymal phase, and these are excretory phases. And all these are dynamic scans, right, where they assess the function. This is called as dynamic scan. And after 3 hours, up to 24 hours, it still remains in the renal system, and you can assess the morphology, that is called as static scans. So it is for both dynamic scans and static scans. Now, what are the applications of this? In case of a vascular phase, you can see and evaluate for the cause of renovascular hypertension. It can be renal artery trauma, renal artery stenosis, or a renal artery thrombus. And also you can evaluate renal plasma flow. So all those can be evaluated. When it comes to parenchymal phase, any congenital anomalies of kidney, like horseshoe kidney or a renal agenesis, and scarring because of recurrent pyelonephritis or vascular reflex, if there is any scarring or pyelonephritis or acute renal failure from a chronic renal failure, and also in the evaluation of a transplant. In excretory phase, You can evaluate if there are any urinary leaks, vesicoeretic reflex, and hydroerythronephrosis. So when it comes to hydroerythronephrosis, this hydroerythronephrosis can be because of a anatomical obstruction. Where there is some obstruction, the urine is not being fast, and that produces hydroerythronephrosis. Or it can be functional. Right? Functional can be either there is no anatomical obstruction, but there is vesicoeretic reflex is there, or there is a non-compliant bladder. Now, in such conditions, what you can do is you can get a diuretic renography, where you give IV furosemide, and after that you get another image. So if it is anatomical obstruction, there is no change. But if it is a functional obstruction, the lots of urine that is produced will overcome this functional obstruction, and the change will be evident. That's how it differentiates a anatomical obstruction from a functional obstruction in the case of HD1. So this is in brief about the radionuclide imaging and